Hi doctors. Am I audible? Hello. Hi doctors. You're going to please hear. Yeah, there is some technical error. Now it's audible, right? Yes, yes. Hi doctors. Yeah, yeah. Just we wanted to start at 5:05. Yeah, because of some technical issue, it 10-15 minutes delay. We'll start early. Okay. So yeah. So in 2 minutes we'll start. So this is a separate session. Okay. For cardiology, it's a special session for you. Okay. So some of because of technical issues, some people went to another live. Am I audible? If I am audible, please type okay. Please type okay if it is audible. Is there in live? Yeah. Dr. Raj Parmar, what happened? Just because of this delay, I opened another live. Yeah. We will start. Okay. So this notes I had uploaded in live drive. Okay. So drive me I opened the notes also uploaded. Please take the PDF, open in your tab. Okay, open in your tab and watch in YouTube. Okay, so here you can see these are my notes. Is the notes are clear for you? So I'll be telling cardiology in very fast way and you will be understanding it. Okay, for example, I'll be discussing about JVP, I'll be discussing about the IHDs and all. Okay, this clarity is good, right? Somewhat okay, right? If any difficulty, you tell me. Okay. So I think we will start. So those who are coming late, so let them see the uploaded video. We have to cover cardiology in 1 hour. Okay, clear? Okay. So I'm starting. Before that, keep the PDF open. Keep the PDF open because I'll be changing the notes inclination angle. So this is a different session. I'm not using pen tab. I'm not using screen and system. This is a fast session. I'll be discussing the cardiology fast. Similarly, I'll be covering nephrology. I'll be covering respiratory system. I'll be covering almost pharmacology, microbiology, and some other topics also. Why I am doing this live session? If I'm doing in my online session, I need to take the video, I need to make the PDF, I have to club it, mix so much of time. This is like just for the exam purpose, just for the NEET PG purpose, we are going to study. So within 10-15 seconds, we will start. So this note you are visible, no? Some notes are visible. So open in your tab, PDF, okay, see that and mark it. So I had put highlighters here. So we are just going to see very important. So in each page, see, you can see very important things are there. So that we will discuss. See, pulses, paradoxes, important, hypertension, emergency. So I'll be discussing these things. Okay, clear? You are understanding, right? So like that, I will discuss very fast. Ischemic heart disease. We are going to study IHD in 10 minutes, 5 to 10 minutes, and completing it fast. Okay, so different things. Okay, acute coronary syndrome, NSTEMI and STEMI. So we'll study within 5 minutes. We'll study what are the important things. Okay, so we are going to study indication of CABG and staging of heart failure. What is heart failure? Acute heart failure. So acute heart failure, different classification. So ECG, we are going to cover exam purpose ECG within 3 to 5 minutes. Okay, so everything, cardiology, almost everything is there, and very important thing. See, axis, how to decide the axis of ECG. I'm going to discuss that also. Okay, so if I'm fast, please comment if it is fast. If you want to repeat, we'll repeat, but we want to cover in 1 hour. So it is almost 5:28. Yeah, 5:30. It is 20 minutes delay. I'm really sorry for that. So we'll start the session. Shall we start? Shall we start? So we are starting the session. Okay, if somebody say okay, we'll start the session. Okay, we'll start the session. So please listen. So in the Focus 30 video, I had explained about JVP. So JVP, what you should understand JVP, you should know right ventricle. Okay, right heart, right ventricle. So right ventricle, if it is pumping up, JVP will elevate up. Okay, so we have A wave, C wave, V wave, three positive wave, X dash and Y dash, two descents are there. So A wave for atrial contraction, that is very important. A wave for atrial contraction, JVP elevates. And we know C wave, bulge of tricuspid valve. Is it happening at isovolumetric contraction? This is very important. They previously asked isovolumetric contraction, bulge of tricuspid valve, and whenever blood is going down, suddenly the valve closes. That will cause an elevation, lift up, and is causing C wave. And we have V wave, it is because of venous inflow, venous filling of the right atrium finished, and X descent because of sudden ventricular contraction, atrial relaxation, and the atria that blood will come down, JVP will fall back. Okay, and Y descent because of atria is emptying. This is important for JVP, and JVP regularly they are asking one question. So A wave, which is very important in different pathophysiology. So giant A waves. So imagine right atrium is contracting very strong because of there is some obstruction in the atrial flow. Right atrial side flow. Right atrial side is going to pulmonary circulation. Pulmonary circulation have some pressure, some obstruction. So atria has to conduct very strong. That's why A wave become giant A wave, pulmonary hypertension. TS, tricuspid stenosis and pulmonary stenosis. So this is very important. Right ventricular diastolic dysfunction, pulmonary hypertension, giant A wave, that is important. Cannon A wave, where you can see cannon A wave. So whenever atria and ventricle are contract same time, imagine atria and ventricle contract same time, all the fluid will go to the JVP stream. It will go to the JVP stream. It will go up. Okay, it will go up and cause cannon A wave. So complete heart block. It can be seen complete heart block and ventricular tachycardia. This is also important. Okay, so absent A wave. We know atrial fibrillation, A wave will be absent, and the P wave will be absent in the ECG as well. This is very important. Clear? So is it audible, right? Is it clear, right? Yeah. So we have CV wave is seen in tricuspid regurgitation as well. Okay, tricuspid regurgitation as well. That is important. So we are coming the mnemonic known as pay tax. Pay tax means pay tax. P, pericarditis. Y. So rapid Y is seen in pericarditis. You can see the rapid Y. Tax, tamponade. We have X descent. So this session is discussed in focus 30 of the fifth module. Okay, clear. So JVP is very important. It is very important. We have to know. Okay, now JVP, that is enough. Now we have to know pulses. Pulse is very important. It's more of a practical thing, but especially we should know few of the characters and the named pulses. In aortic stenosis, we are getting pulses parvus et tardus, slow racing pulses parvus et tardus. So it's a low volume, slow racing pulse seen in aortic stenosis. This is very important. This also asked. And water hammer pulse or collapsing pulse. So this is also very simple. Regularly hyperdynamic circulation, thyrotoxicosis, anemia, beriberi. So all these cases, and aortic regurgitation, water hammer pulse or collapsing pulse. We have to demonstrate in our practical also. This is also very important. So from the pulse, these two are important, and we will discuss a few of the thing also. JVP we already discussed. If you have any doubt, watch Focus 30 fifth module. Okay, just two topics are I covered in cardiology from the Focus 30 session. Okay, now BP is also. So we covered JVP, pulse. Now we are going to see the BP. So in the BP session, you have to know Indian guidance for hypertension 2019 criteria. So stage 1, 2, 3, you have to see the ranges. So if it is more than 140/90, more than 160/100, 180/110, they are divided into stage 1, 2, 3. This is very important. Okay, so that is clear. So 140/90 stage 1, 160/100 stage 2, more than 180/110 is stage 3. This is also important. So we are starting with small topic to we are going for the big topics. Okay, so 140/90 we have to start the treatment actually. So 130/80 in coronary heart disease or heart failure, we have to start the treatment with even 130/80 also. This is very important. Okay, and This is clear. These 2 points are clear. Now there are management. We have age less than 60 years. We usually go for AC inhibitors or ARBs, and age is more than 60. We'll go for calcium channel blocker. This is just practical point view. So these and all they won't ask in exam, but these are simple topics. You should know this. Okay, you should know this. Okay, clear. Now we are going to see hypertension crisis. From here, they will ask some questions, direct questions they'll ask. So, you know what is hypertension crisis? The BP is elevated more than 180, 110 or more than 120. Systolic and diastolic pressure both are high. And we have something called urgency and emergency. So what is emergency? E for E, there is an end organ damage. There is an end organ damage. So because of that end organ damage, usually it is seen in dissection of aorta dissection, sudden chest pain, and BP is high. Pheochromocytoma, related to adrenal gland. Preeclampsia, obstetrics. These conditions, especially the BP will be very high, and these are present with end organ damage. So management is very important. These are compelling condition, very important. And urgency, there are no end organ damage. We can manage with the drugs treatment. Okay. So emergency drug management to you leave, but you should know something like you have to avoid rapid arterial dilatators. Why? It is rapidly dilating. It is causing severe problem. Drugs like hydralazine, diazoxide, minoxidil, nitroprusside. We have to avoid these rapid arterial dilatators in this hypertension emergency. This is one important point. And I already told dissection of aorta. Dissection of aorta is a cause for this emergency. So drug of choice for dissection of aorta is nothing but beta blocker. Okay, beta blocker plus nitroprusside. These are the drugs. So drug of choice for dissection of aorta is important. That is beta blocker. You have to know this. And you have to know one more thing. What is acute pulmonary edema? Is nothing but acute heart failure, especially the left ventricle, left LV systolic dysfunction. In this case, beta blocker should be avoided. Beta blocker should be avoided in acute pulmonary edema, acute heart failure, LV, left ventricular, acute pulmonary edema condition. Beta blocker should be avoided. That is very important. Okay, clear. Okay. Then one more point, ischemic stroke, any neuro stroke, we cannot give nitro. No nitro in neuro. No nitro in neuro. Why? No nitro in neuro, because this nitroprusside, nitroglycerin, and these related compounds of nitro group, it increases the intracranial tension. So that is also a risk factor for the already developed ischemic stroke, where BP is or more than 180, 200 systolic pressure. So don't give nitro compounds in ischemic stroke, neuro condition, especially because this increases intracranial tension. Clear? Clear. So this is also very important, right? This is also very important, right? Clear? So hypertension emergency, these are the potential questions. Rapid arterial dilatators don't give. Beta blockers are drug of choice for dissection of aorta. And acute heart failure, pulmonary edema, what is this management? Ischemic stroke, and why you are avoiding nitro related compound because these causes increased intracranial tension, to avoid that. Okay. So just pulse we are discussed. Now we have to discuss something called pulses paradoxes. So you know what happened normally, whenever inspiration, during inspiration, the systolic blood pressure falls by 5 mmHg. That is normal. The systolic BP falls by 5 mmHg in inspiration. That is normal. So you should know the mechanism. We should know that mechanism. Just leave. Okay. So what happened in pulses paradoxes? Paradoxically, even though it is named paradoxes, what's happened? Even BP falls more than 10 mmHg. More than 10 mmHg. Here the BP falls more than 10 mmHg. These are seen in condition like cardiac tamponade and the chronic airway diseases like asthma and COPD. These are very important. Pulses paradoxes during inspiration, usually 5 mmHg of the BP fall will be there, changes will be there 5 mmHg. But here this condition like cardiac tamponade and this airway diseases, asthma and COPD, it will be more than 10 mmHg. This is known as pulses paradoxes. There is no paradox actually here. Clear? This is also final year practical topics. Okay, final year practical topics. Now you come up with something. So murmurs I already covered in the 13th module of Focus 30. Single slide I cleared all the murmur with images. That is very important. And there is some condition called a reverse split, wide fixed split, and this and all usually they want to ask for our NEET exam. But you should know Focus 30 ka session mein 13th module, the first session murmurs ka video I had explained there Please watch that, because that 10 minutes, 15 minutes may I explain, you will never forget that how to diagnose diastolic, systolic, end diastolic, like that. Okay, clear? This is very important. Okay, clear? S3, S4, they won't usually ask for NEET exam, but you should know it is good actually. Okay, but we are not going to discuss that. Opening snap things, ejection click, this and all, usually they are not asking any related to the diseases. They will ask, just you can watch that also. Okay, clear? Okay, so clear till as far as now we are going little fast. Our major topics are coming, waiting there. Our major topics are waiting there. Okay, okay. So classes started just 7 minutes. We are completed some important topics. Okay, some hypertension crisis, BP. We covered about pulse. We covered about JVP. Now we are going little fast, and this is the important area: ischemic heart disease. IHD. So IHD, we have stable IHD and acute coronary syndrome, ACS. Okay, stable IHD, nothing but angina pectoris. ACS may we have STEMI, ST elevation MA, non-ST elevation ME, and STEMI and STEMI. These are very important. So this is important because stable IHD, no plaque, no plaque rupture, pain on exertion will be there. So that is a classification, but this is different. So we have to know there are many things to learn, but we are just learning what is angina. Angina, there are three main characteristics features are there. One is the typical pain. We can say the typical pain, and the triggered by exertion or emotional stress and subside on rest. These are the three classical features. And the typical pain, which is retrosternal, compressive feeling up to neck, umbilicus, both limbs, single limb, back, radiation will be there to that side, and it is associated with exertion, emotional stress, it is triggered, and subside on rest. These three classical features will be there. That is angina features. In that, all the three are present. It is known as typical angina. If all the three are present, it is known as typical. Only two are there: pain that triggers on exertion, exaggerated on exertion, subside on rest. All the three are typical angina. Only two are present, atypical. None are present, or one or none are present. It's not non-anginal pain. These are the classification. You should know this. Okay, you should know this. Okay, now we'll go and see the management of angina: beta blockers, nitrates. Okay, first line treatment: nitrates and beta blockers, calcium channel blockers. Ranolazine is a sodium channel blocker, and you should know what is ivabradine. I4I. This is blocking the IF channels in the SA node and decreasing the heart rate to manage the heart rate. So it is blocking the SA node. So directly related to the heart rate. I4IF, ivabradine, IF channel is blocked. This is also important. They can ask this question. Okay, so if it is still we are managing the angina, if it is not managed, still angina is present, we have to go for CABG, PTCA. So this percutaneous transluminal coronary angiography or the coronary bypass grafting, all are depends upon the patient condition, and usually they won't ask this. Okay, you should know whatever I explained. When it comes to acute coronary syndrome, you should know, see, you can see the vessel and there is some block is there. Okay, so the lumen will be partially patent and complete occlusion. If it is partially patent, if it is complete occlusion, the ECG findings will be different and the management will be different. So it is like it is completely blocked, and the myocardium will be in infarction. So it's a transmural infarct. ST elevation will be there, so it's known as STEMI, ST elevation MI. And lumen is partially patent. That's why chest pain at rest, ischemia in muscle. So it can happen because of multiple reasons. So it can be due to maybe due to a unstable angina. Okay, unstable angina, and it can be a non-ST elevation MI also, where ST depression can be seen. So if it is the whatever this partial block, if it is unstable angina or NSTEMI, they have chest pain at rest. Okay, and it is crescendo type pain will be increasing, and ECG showing ST depression. We have to go for the cardiac troponin marker. So this has to be managed by anticoagulation and antiplatelet drugs, and we should know aspirin, P2Y2 blockers, and anticoagulation, low molecular weight heparin, and all unfractioned heparin. So this also very important. So we have to do troponin assay. If troponin is coming normal, this is because of unstable angina. If troponin is high, which is a cardiac marker, it is a MI myocardial infarction, and that is non-STEMI, non-end STEMI, that is also you have to know. So this area you should know. This area you should know. ECG, ST depression, ECG, ST depression. If it is troponin is normal, it is unstable angina. If it is troponin high, it is end STEMI. This you should know. If ST depressions are there, no, you should know ST depressions are there. Avoid thrombolytics. We cannot give the thrombolytic in end STEMI, ST depression. We have to avoid thrombolytic. That is very important. So this is also a very important point. ST depression, we have to avoid the thrombolytic. This is very important. Okay, so we are done angiogram, then we did PTCA, CABG. Okay, so these one all done. Okay, so these are the management of unstable angina or end STEMI, especially if ST depression. Avoid thrombolytic. This is an important point, and you should know this the features, anticoagulation and antiplatelet. Usually they won't ask that much. You should know the criteria of angina, 3 features. That is also very important. They can ask a question like that also. So that is clear. Now we are going to the very important STEMI part. STEMI, you should learn pathology also. Why? Because pathology, I'm telling the people are watching. Yeah, people are getting this. You are watching this. So anyway, I'm continuing. Somebody, if he's listening, please put a okay or hi. So we are just discussing the important parts from the notes. Please keep the notes on. Somebody is there. Yeah, I'll continuously. Okay. So this video will be uploaded later also. Okay. So see STEMI. Now we are going to see the STEMI. STEMI, it is very important. There is ST elevation. ST elevation will be there. Whenever there is ST elevation in an ECG, there will be a reciprocal ST depression in the opposite lead. So we are going to see the ECG soon. So that is one point. So classical features of ST elevation will be there. Everybody can, even in exam question, it is easy. You can understand that also. Okay. So we have something called cardiac marker. This is also important. We know troponin, CKMB, myoglobin. So we should know these cardiac markers. You can see the graph also. So cardiac marker, in the first 2 hours, myoglobin is elevated, 2 to 4 creatine kinase, 4 to 8 hours, usually 4 to 8 hours, this troponin, because of the infection, 4 to 8 hours, this troponin is coming into the play, and 6 to 12 hours CKMB. Okay, this is also important. The highly sensitive troponin, within first hour only we can detect it. So these are the cardiac markers. You should know the troponin. We should know the high sensitive troponin and the CKMB. These are very important. Usually, whenever in ICU or setup, we will be sending this. Okay, we will be sending these to investigation. So this is about cardiac markers. This is very simple. So we know whenever this case comes, we have to give aspirin 325 mg. We are given in the casualty. We have to give oxygen support. We have to give nitrate, morphine to reduce the pain. Most of the cases in MI, pain is the cause of death. So nitrates for dilatation, symptomatic benefit, relieve pain, morphine, beta blocker, oral. So we have to manage this and all. They won't ask this part, but they will ask this. So immediately we know there is some occlusion, whether we can go for the TT, thrombolytic therapy, or percutaneous coronary intervention. This is very important. Why? Because imagine from a tertiary center, you are referring to the cardiology unit. If you have anticipated time is there, for example, anticipated time to do PCI more than 2 hours, you don't have option. You have to do for thrombolytic therapy. Okay, so 2 hours, more than 2 hours anticipated time, we have to go for TT. There is no option. But anticipated time to do PCI is less than 2 hours. We can go for the primary PCI. The percutaneous coronary intervention is the important, so we can go for that. But it is far away. The center is far away. We cannot do PCI. We have to go for the TT. Okay. So this routinely till 12 hours we can use TT up to that. After that is not beneficial. Okay, that is also is there. So this is the one point you should remember. Okay, so one important point they may ask you, what are the contraindications of thrombotic therapy? So previous history of intracranial bleed or HCM stroke, hemorrhagic stroke, intracranial bleed or hemorrhagic stroke, we cannot go for TT, thrombolytic therapy. AV malformation, we cannot do. And recent ischemic stroke, we cannot do ischemic stroke. And aortic dissection, we cannot do. And active bleeding or bleeding diathesis, we cannot go for the thrombolytic therapy. This is very, very important. Okay, this is a very important one. And percutaneous interventions we can do if it is less than 2 hours, or else we should go for the TT. Okay, that is also important. Okay, so you should know what is TT, what is percutaneous coronary intervention, what is the contraindication of thrombolytic therapy, and what are the basic things. So definitely, if it is a question, ECG may you can see the proper ST elevation. I am going to teach the ECG also soon. Okay, so what is the indication of CABG? Indication of CABG. Okay, what is the indication of CABG? See, triple vessel disease, TVD, very important. All the three vessels with more than 50% involvement. And LMCA, so LMCA more than 50%, LAD, left artery, left LAD proximal lesion. So these are very important. Okay, so left coronary artery, more than 50% block, LAD. So you should know what these 3 points. Okay, just you should know this is sufficient indication of COBG. So you say triple vessel disease. So that is also important. They may ask, not sure, but this is also important point. Okay, clear. Okay, now so see, now it is not end here. So we have to know the ECG pattern. That is, they are going to ask regular. I am going to discuss that ECG pattern soon, after immediately this. Now before that, we are going to see heart failure, which is an important topic. So we have heart failure with a reduced ejection fraction, which is less than 40%, with preserved ejection fraction, which is more than 50. This is also important. We know right heart failure, left side. What are the important things? Right side increased JVP, hepatojugular reflex, left side of the dyspnea on exertion, paroxysmal nocturnal dyspnea, orthopnea. These classical features of left side and right side you should know. That is important. You can differentiate right and left, that's all. And that is also important. So now we should know the staging of heart failure. So all the things are important, but you should diagnose it with whether it is left heart failure or right heart failure. After that, there is staging of heart failure. According to staging, the management will change. So we will see the staging. We are staging into A, B, C, and D. A, nothing but the staging of heart failure. A, what is the risk factors are there? Risk factors like hypertension, diabetes mellitus, family history, and smoking. These are the risk factors. Risk for developing atherosclerosis syndrome. Okay, these are important. And what is B? Along with the risk factor, there are some structural defect. Echo, but it is asymptomatic. There is no symptom. Asymptomatic. So asymptomatic. So we can start AC inhibitors, beta blockers. Okay, but we have to avoid or stop the calcium channel blockers in the B stage. So A have risk factors, B have some structural defect but asymptomatic. But if they have to avoid calcium channel blocker, we can give AC inhibitors and beta blocker. Okay, and what is category C? Staging C, structural defect plus symptomatic. They have symptoms. So what are the management? So the management include ARNI, angiotensin receptor inhibitors, and neprilysin inhibitors, ARNI. This is very important. And you can see valsartan plus sacubitril. So these are important. And we can go for diuretics, beta blockers, like that we can go. And ARNI, ARNI, this is also very important in the stage C, where structural defect and symptomatic symptoms will be present. Okay, what is group stage D? Stage D, refractory heart failure. Yeah, there is SGLT2 inhibitors also is there, you can say. So it is whoever in diabetes plus or minus, we can go for SGLT2 inhibitors. Can use in both reserved and preserved, reduced and preserved heart failure also. So see, there are so many drugs. We cannot study all things. So we cannot, nitrates is there, hydrolysin is there, ivabradine is there. So many things are there. We cannot study everything. So mainly ARNI, this is the preferred drugs order. ARNI, diuretics, beta blocker. Then we have to see this. We have to go for spironolactone according to the potassium level, creatine level, and SGLT2 inhibitors. If we discuss that, it will go to 2-hour, 3-hour session. We'll just see the important part. Yeah, good. At least you are in track. So if it is refractory heart failure, regular refractory heart failure, and failure to management of this ARNI, even SGLT2 inhibitors, nitrates, nothing is working. This is known as stage D. we need assist devices or cardiac transplant. So stage A, stage B, stage C, and stage D. Stage D, definitely we have to go for cardiac transplantation. Stage C, ARNI, diuretics, beta blocker, SGLT inhibitors, spironolactone. Stage B, we can go for AC inhibitors and beta blocker. We have to avoid the calcium channel blocker. This is very important. A, B, C, D, heart failure with reduced ejection fraction and preserved ejection fraction. These are all very important things. Okay. So beta blocker is the single most drug increase survival of the patient. So there are few benefits for each drug also. Though this is why cardiology is very demanding and important. Okay, so NYHA classification things are there. Now we should go for something called acute heart failure. Acute heart failure, in the middle of the night, patient comes with sudden breathlessness, SpO2 fall, BP fall, tachypnea, tachycardia in the night. This is usually have seen in the middle of the night, 12 o'clock to 3 o'clock time, they will come to the casualty. So what happened? The classification according to the perfusion. So these patients have really congestion features because of the congestion, and perfusion will be reduced to pulse rate. So you can see the congestion, pulmonary edema, increased JVP, Krebs, S3 level, and perfusion, pulse, low pressure, and cool extremities, hypotension. So there will be perfusion problem and congestion problem. So what happened? We have to make proper perfusion. So that means we have to make them warm, and we have to clear the chest, make it dry. We have to clear the fluid. So we have to make them dry and warm. So the classification is dry, warm, and wet, warm, dry, cold, and wet, cold. So the management is easy. We have to make the patient dry and warm. For example, if wet, warm, there is some wet means clear fluid is there. We have to clear the fluid. How? We can give diuretics. Simple. Dry means dry means dry is okay. Cold means cold extremity means poor perfusion. We have to start the inotropes. That's why wet, warm. So warm is fine. We want warm. So wet means we have to give the fluid out. That's why diuretics. Dry and cold. Dry is okay. No problem. We want to dry. Cold extremity. We have to start the IV fluid and inotrope. Wet and cold, both diuretics and the inotropes. See, that is why the management according to this classification. This is very simple once I explain this. Okay, dry, warm, we have to make them dry, warm. It is dry, cold, we have to clear the cold. If it is wet and warm, we have to clear the wet. Both wet and cold, this is worst condition. We have to clear with both diuretics and inotropes. Okay, clear. Okay, you are getting right. I'm little fast because this is our hyper revision series. Just to see the topic after cardiology, this portion, what you have to do, you go do some 10 to 25 custom module and just attend the paper and come back. Okay, like that. So clear. Now we are going to see the important area, that is our ECG. So this you studied in physiology. This slope you have to know in ECG each area may. So here you can see the calcium influx. That's why it is going up. Calcium influx. Okay, it is in the SA node and it peak. Then potassium out, and it's coming low, and potassium is out. Okay, and it is, you can see the 0, 3, and you can see the 4. Okay, so then it is going like this. So imagine the slope is coming here, heart rate increases, number of waves will be more. If it is delayed, heart rate is decreased, number of waves will be less. So that is why this application. Phase 0, because late acting calcium channel. Phase 3, potassium efflux. That is important. See the graph. This is very important. Physiology or medicine, they will ask this topic. Okay, this topic. Okay, and phase 4, sodium and calcium channels both are there, responsible for the automaticity. If it is early, more heart rate. If it is late, less heart rate. Okay, clear. Okay, digoxin suppress insulin. This is we will discuss in pharma also. So this is basic physiology. You should know this. Okay, you should know this. Now we will see. We are going to see the basic of physics. Basic of, you know, in the one triad is there. Many things are there. Don't want to study. Just we are going to study very simple diagram, and we are going to clear the ECG. So imagine this is our heart. Okay, this is our heart. So we have different leads. Okay, so lead 1, lead 2, lead 3. So I kept one lead. So you can see in Endovan triad, lead 1, lead 2, lead 3 in 60-degree angle. So here same. So lead 1 I kept at 0 degrees Celsius. Lead 2 next to 60, it is 60. Lead 3, 120. So lead 1, so just to draw this, you are going to solve all ECG type. Lead 1, you are going to see 0, lead 2 60, lead 3 120. So, and you should know lead 1, 2, 3. Along with lead, we have other leads, AVF, AVN, and AVR. And lateral leads like chest leads are there, V1, V2, V3, V4, V5, V6, V1 to V6. So you should know this mnemonic: 1, 2, 3, FLR. You write this FLR in alphabetic order: F first, L then R. 1 for F, 2 for L, 3 for R. So for 1, F will be exactly perpendicular. 2, L will be perpendicular. 3, it will be perpendicular. You can see here. This is lead 1, F is perpendicular, and lead 2, you can see this L is perpendicular. Lead 2, L is perpendicular. Lead 3, R is perpendicular. So you can see 1 AVF, 2 AVL, and 3, these are perpendicular. So now you come and see the graph. For 1 F is 1, first F is perpendicular. AVF is coming 90 degree, clear. Then 2, 60 degree, perpendicular means AVL here minus 30, 60 plus 30. So here it is 0 going minus 30. This is 0. This is 180. Okay, so it is minus 30. So AVL is perpendicular to 2. Now we have 3, lead 3. So we have AVR. AVR, it is vertical. So we can say this point. This is plus 210, or we can say minus 150, minus 150. So it is minus 150. So this is the orientation in the heart. So now if it is the heart, you can see 3 AV1, 2. These are nothing but inferior leads. So we can see the heart inferior leads. So in these leads of any changes, ST elevation problem, we can say it is inferior wall lesion. Okay, clear. And we can see this side. This is the right ventricular side. This is the left ventricle. This is the apex. So 3 is corresponding to the right ventricle. Clear, like that we can say. So we should know 1, 2, 3 FLR, how this vertical. Now we are going to solve all the ECG and things. Okay, clear. Now we know we have chest leads V1 to V6. So V1 to V6 is nothing but we have R wave progression. In the V1 R wave, QRS complex will be like this, and S will be more, and later on it is coming biphasic, increasing, and here we can see proper R. This is known as R wave progression. This is also very, very important in the chest leads V1 to V6. This is also important. Now you can see how these chest leads are placed. So see V1, V2, V3, V4, V5, V6 they place. So you can see V1, V2 through the right ventricle side or the septum side. So this is the septal leads or right ventricular leads, and we can see V3, V4, which is the anterior wall of the left ventricle. Okay, and V6, V5 is the lateral leads of left ventricle. So how this ECG changes, we can tell which is inferior wall MI, lateral wall MI, and like we can differentiate what kind of MI in that. Okay, this is clear. You should know this part and this part. Okay, just understand this is enough. Okay, so I told in R wave S will be more here, so V1, and R will be more in V6. So in LVH S in V1 plus R in V6, if it is more than 35 small boxes, we can say it is left ventricular hypertrophy, because in the V1 S will be more pronounced, in the 6 and R in the 6 R will be more pronounced. R will be more. This is S will be more pronounced. So we can see here S will be more pronounced, R will be more pronounced. So we can see SV1 plus RV6 more than 35. We can see it's LVS. They won't ask, but you should know. Simply they will ask. If simple question, you can answer that. Clear. And leave about this. Now we have something called a right bundle branch block, left bundle branch block, and all. Just we are going to see we have heart. Okay, we have something called SA node. It is generating heart rate. Some abnormality. This is the way electricity is passing. Okay, this is the way electricity is passing. So some block is happening, or some additional some are there, some problem are there, or additional pathways are there. Everything will change. It will become pathology. So left bundle branch block and right bundle branch block, just study this mnemonic: William Marrow, William W. So V1 to V6 William. So V William, and see V6 M, left one. See both L are there. Left bundle branch block. Okay. Marrow, RR, right bundle branch block. V1 we can see M pattern, and V6 we can see W pattern. So you can see only see here left bundle branch block in the V1. So left bundle, it is known as William. So here V1 and V6. V1 may W. So you can see a W here. Okay, you can see the W here. Okay, William. Okay, clear. Okay, in the V6 you can see the M pattern. So this is V6. This is V6 and this is V1. This is V1. WM, William. This will be ulta in RBB, right bundle branch block. It is written there. So marrow, M is V1 and 6 may you can see W, marrow, M, W, V1 may M. So this point is enough to learn for RBB and LBB. So RBB, you can see marrow, LBB, William, marrow. Clear. This is important. Okay, clear. So after that, we are going to see the axis of the ECG. Axis of the ECG, it is very important. We are going to see the axis of the ECG in 1 minute. So can you tell what is right axis deviation? What is left axis deviation? So it is little confusing. Yeah, it is little confusing, but you should know what is axis. Okay. So before that, you just see here. So this is the heart different. This is the 0 degree. This is the 90 degree. Now we'll see individually. So for the axis purpose, we have to see QRS complex in the lead 1 and lead AVF. 1 and AVF is vertical. No, we are just seeing the lead 1 and lead AVF. Okay. Now imagine. See this. Imagine you are seeing, right? So seeing. So this is 0. This is 90. Okay. This is 90. This is 180. Okay. So we know what is the normal axis of heart. So it is from minus 30 to 90. This is our normal axis of heart. Okay, this is the normal axis of heart. Any deviation, we will say abnormal axis. Now we will see what is happening. Now in the, you can see lead 1. So lead 1 is there, AVF is there. See, lead 1 is positive. So lead 1 positive means lead 1 is positive. Now lead 1 is positive. No. So lead 1 is positive. That means it is from, this is from here. So minus 90 to plus 90. So this is minus 90. This is plus 90. Lead 1 is here. So it may be here. It may be here. It is positive in maybe this region. And AVF is positive. So where is AVF? Exactly vertical, no? Exactly vertical like this. So it is here. So both graphs are coinciding this point. So this will be their axis, and this is normal axis deviation, normal axis only. Clear. So now we'll go and see one more. So now we see here. Now you see here what is here. So lead 1 is like this, negative. Lead 1 is negative means, so lead 1 is negative mean, what is lead 1? Lead 1 is this 90 degree. If it is negative mean graph is this side. Correct. This is positive mean we can draw this side. Okay. So the lead 1 is negative this side, and AVF is positive. So where is AVF? It is here, this side. So what is the common here? This one. So this is having right. So you can see right axis deviation. Here is the right heart. Here is the left side of heart. Here is the apex. Okay. So this is right axis deviation. Simple. So okay. So like that we have to go with the QRX complex with lead 1 and AVF. This is very important. Okay. Clear only, no? Clear. Video is clear. Somebody is seeing. How much time we completed? 40 minutes. We have to complete in next 15-20 minutes. Somebody is there? Hi. I am not seeing the comments and all. Anyway, I will be uploading this video also. If somebody is there. So I wanted. Hi, Dr. Lisa. Yeah. Okay. So we will complete this. Axis is completed. Very simple. You should know this. Now we will go and see the cardiac arrhythmia. Definitely question will come from this area. Cardiac arrhythmia, how it is happening, re-entry, automaticity and all. So we don't want to know the pathophysiology. Now we'll go and see the each diseases. Now we'll see here atrial fibrillation. Already we know there is no A wave in ECG and there is no P wave. And we have to say atrial fibrillation. There are many risk factors, hypertension, IHT, VHT, so many risk factors, and the atrial rate will be 300 to 550 beats per minute. Okay. So atrial fibrillation, irregular pulse, and QRS is normal, fluctuating RR interval, no P waves. These are very important from the ECG. So whenever we see the rate, RR interval, so we'll check the RR, it is irregular. So that's why we can see irregular pulse and all everything. So atrial fibrillation is very important. Okay. So ECG, JVP, we can rule out, and pulse, it is very important. So the management of atrial fibrillation is very important. Atrial fibrillation, we have rate control, because high rate and rhythm reverters both are there. Rate control, we should know A, B, C, D. We should know A, B, C, D. A for adenosine. Okay, so adenosine. Okay, two rate controls. These are the drugs for rate control and rhythm reverters. Okay, adenosine. B for beta blockers. C for calcium channel blockers. D for digoxin. These are slows the conduction in the AV node. These are reducing the heart rate. So reduce the conduction in the AV node. And what are the rhythm reverters? How to change the rhythm? Ibilitide and dofetilide, amiodarone, procainamide. So these class 3 potassium channel blockers, class 1A sodium channel blockers, this can use the rhythm reverters. This we will study in pharmacology. We will study in pharmacology. So whenever they will give a simple question, we will see the ECG. We have to see the RR interval. We have to know the pulse. We have to know the QRS complex will be normal and RR interval will be fluctuating, and no P waves you can see, JVP no A waves. This is giving atrial fibrillation. This is very important. Okay, very important. Okay, so there are something called anticoagulation. Anticoagulation also very important, because this is highly hypercoagulable state. We have to use warfarin. Where we will use warfarin? In severe MS, prosthetic valves, we are going for warfarin, only warfarin. Severe MS and prosthetic valve, we are going to see only warfarin. What is direct oral anticoagulant agents? DOAC, this epliciband, rivaroxaban, dabigatran, this can be used in anticoagulation as well. So atrial fibrillation, this is completely we'll discuss in pharma one day. I will discuss CVS pharma because it is highly important. Similar way only I will prepare, because I cannot make PPT and take class and this moment. That's why I'm going live. Okay, please, anything wrong or like difficulty in see, so I am moving this. So any difficulty, see the PPT. Okay, so some limitations are there. Please understand the situation. Just I want to teach. Even 10 students is watching or 20 students is watching. This is definitely will help you. You can cover it in 1 hour. Okay, 1 hour. Okay. Similarly, atrial fibrillation, we have atrial flutter. P waves are continuously occurs. Here P waves are continuously occurs, and so too you can see P waves are continuously appears here, and you can see the P waves and sawtooth appearance you can see here. So in this condition, we have to go for carotid massage. We have to go for some maneuvers and all. Okay, this is very important, and management is same as like atrial fibrillation. Okay, it will be the atrial flutter, and the maximum rate is 150. Atria will be flutter like this. Okay, that's all. That's also very important. Management is similar to atrial fibrillation. You can see the many P waves, and it's like sawtooth appearance. You can see the sawtooth appearance that is in ECG. So I will send the photos of ECG also. Please check this ECG pattern also in the marrow or any corbett here. Okay, please see that. Supraventricular tachycardia, SVT, PSVT. This is very important, because we have AV NRT, atrioventricular nodal reentry tachycardia, and things are there. So AV NRT, we should know retro-inverted P wave. P waves are retro-inverted. Okay, that is very, very important. Our RR interval is normal. RR interval is normal. Okay. So lead 2 is the best to analyze. So here in this PSVT ventricular tachycardia, we have to do carotid massage. This is the first step. First step is carotid massage. Vagal maneuvers, Valsalva, we have to do cold water phase. This is very important. And then drug of choice for PSVT is nothing but our adenosine. PSVT, drug of choice is adenosine. Very, very important. We have to start with 6 milligram, repeat to 12 milligram, again 12 milligram, and 3 doses. We can give maximum 3 doses. 6, 12, 12. Adenosine is the drug of choice for supraventricular tachycardia. Okay, clear. So one will WP syndrome. Okay, Wolff-Parkinson-White syndrome. There is bundle of Ken, re-entry will be there, accessory path is there. Because of that, you can see something called PR interval, like P segment, PR segment, short PR interval, because no PR segment. QRS bone, we can see this is known as delta wave. We can say that this wave is known as delta wave because of the re-entry bundle of Ken. Okay, so we have to treat it like AVNRT. So carotid massage, adenosine, beta blockers, like that we have to treat. Okay, this is also important. Wolff-Parkinson-White syndrome, delta wave, short PR interval because no PR segment. So it is, see, after P wave there is no segment directly and so this is known as delta wave. You can see the delta wave. This is very important here. Okay, so One more important thing, WPW syndrome along with atrial fibrillation, if both are present, so ABCD is contraindicated. Don't block AV node. You see, imagine already one extra site, say bundle of candy is there, so accessory path is there, and atrial fibrillation is happening. So if you block the AV node, so it won't work, okay, it won't work. So management is amiodarone. This is very important. This is a potential question also. This is very important. Wolf Parkinson WPW syndrome along with atrial fibrillation, management is amiodarone. Don't go for another. Okay, so here supraventricular tachycardia, carotid massage, these maneuvers, adenosine, then beta blocker, CC, calcium channel blocker, ABC, okay, and the cardioversion defibrillation. So this is the management. But if it is associated with WPW syndrome, AF, we can treat amiodarone. WPW syndrome managed like our supraventricular tachycardia, but it is associated with atrial fibrillation. We have to use drug of choice as amiodarone. This is very important. So we have ventricular bigeminy, ventricular trigeminy. You can see every alternate beat is an ectopic. It is known as ventricular bigeminy and trigeminy. So it is also very important. Okay. So we have to give something called shock to revert this. So shock should be given at the peak of R wave. This is also very important question. And we have synchronized shock and non-synchronized shock. Synchronized shocks are given in cardioversion at the peak of R wave, and non-synchronized waves known as defibrillation is given in pulseless electrical activity, pulseless ventricular tachycardia and ventricular fibrillation. This is very important. Definitely they are asking and you will get confusion. Synchronized shock is given in cardioversion, synchronized cardioversion at the peak of R wave. Non-synchronized known as defibrillation, we are going to defibrillate. So pulseless ventricular tachycardia and the ventricular fibrillation, these are very important. Okay, and so what is the management of ventricular tachycardia? If it is unstable, pulse is present, cardioversion, we can do cardioversion. Pulse is not there, defibrillation. See how the management is changed. Ventricular tachycardia unstable, pulseless, it is defibrillation. If it is pulse present, cardioversion, very important. So, and if it is not unstable, it's like symptomatic, the drug of choice is amiodarone. Ventricular tachycardia, drug of choice is amiodarone. Wolf Parkinson White syndrome, WPW, AF is amiodarone. This is also very important. Nothing but we have prolonged QT, polymorphic VT, polymorphic ventricular tachycardia, polymorphic, that ECG is there, ECG we have to see. So you can see the ECG is there. So long QT, see, small amplitude and large amplitude, cyclical pattern, polymorphic VT. This is a classical diagram. So drug of choice is beta blocker, polymorphic VT, drug of see polymorph, different morphological features you can see, some large, some small amplitude, large amplitude mix, polymorphic pattern. Drug of choice is beta blocker. This is also important. Okay, so clear. So ventricular fibrillation also is there. So defibrillated shock should be given immediately. Cardiac asystole. So cardiac asystole, flat line. It's flat line. So if you give shock, what is the use? No use, no shock work. You have to go for CPR. This is very important. This is a simple question. And this if you make mistake gone on, many people without concept they will fall for this. Cardiac asystole means nothing but it's a flat line. Flat line may the shock won't work. We have to go for the CPR. Only CPR 30:2, 30 compression, 2 ventilation. We have to give. Adult and pediatric is different. Okay, clear. This is also important. Now we will see heart block. Heart block is very important. Why heart block is important? So we have type 1, type 2 and type 3. Type 1 means prolonged PR interval. The PR interval is prolonged. So PR interval is prolonged in type 1. So you can see the PR interval is prolonged here. That is type 1. Type 2, we have Mobitz 1 and Mobitz 2. Mobitz 1 means progressive prolongation of PR interval. So you can see the PR interval is here. Then the PR interval is increased and the PR interval is increased. And you can see missed QRS. The QRS will be missed here. See, one QRS second. Here there is no QRS. Okay, so QRS is missing. Okay, QRS is missing, missed QRS. And Mobitz 2 fixed PR interval. Mixed PR interval. This Mobitz 1 is known as Wongi-Bax phenomena, where walking P wave, like that you can see Wongi-Bax phenomena. This is also important. So type 1 prolonged PR interval, type 2 there is missing QRS and progressive prolongation of PR interval in Mobitz 1, Wongi-Bax phenomena, fixed PR interval in Mobitz 2. Type 3 is known as complete heart block. Type 3 is nothing but our complete heart block. Okay, so complete heart block, what will be there? JVP, canon A wave, RR interval will be equal. No, so here PP interval is same, RR interval is same, but they don't have any connection. Some P PP. So P and P gap will be same, but they will be overlapping. They will be not in synchronization. So there is no association with each other. PP interval will be same, RR interval will be same, but it is like that. So it is like there is no connection between these two, but it is regularly proper interval. It is going. All bradyarrhythmia, drug of choice is atropine, except Mobitz type 2 and type 3. Type 3 heart block, pacemaker is the drug of choice. In Mobitz 2 and type 3 heart block, pacemaker is the drug of choice because bradycardia is happening. All bradycardia, drug of choice is atropine except Mobitz 2 and type 3 heart block. These two also, this point also very important. So heart block also a potential question they can ask. Okay, so you can see the Wongi-Buck's phenomena known as walking P waves. So prolonged PR interval and missing QRS can be seen. That is type 1. Okay, clear. Now hello, sound undo? Hello, sound is ready. Any technical problem? First time I am doing live video and in a limited setup in a fast way. That's why. Now audible. Is it audible? Somebody is there? Hello, audible? No audio since what time it started? Just 1 minute only, no? Now it is audible, right? So just now we'll start it again from this point. MI changes. Yeah, we have anterior wall, lateral wall, anterior lateral wall. So here before in the ECG part I discussed that part. Okay. Yeah, 1 minute. Thank you. So in the beginning part only I had told here you can see 3 AVF and 2 3 AVF is inferior wall. One is going to left side. Okay, left side. This is right side. When in the lateral leads we can see V3 V4 are anterior leads. And V1 V2 in the right side, and V6 V5 it's the lateral wall of the left ventricle. So that's why same thing is here. So same thing. So lateral wall V5 V6, anterior wall, and the anterior wall V3 V4, and inferior wall 2 3 AVF. So see this ECG may any changes we can go for either inferior wall MI, anterior wall MI, lateral wall, anterior lateral. So this is important because we have to differentiate, and the option may there will be anterior wall, lateral wall, inferior wall. You have to differentiate according to the leads. So ST elevation in the lead. They can a simple question from here also. Now clear? We'll go. Okay. So hyperkalemia, which is very important, we have tall T waves, pointed T waves. In MI, blended T waves, arc-shaped blend T waves will be there. And hyperkalemia is nothing but take the ECG, stretch. So it is like it is stretched, pointed. Stretch the ECG, that is known as hyperkalemia. Okay, hyperkalemia. This you should know. Pointed T waves, this stretching of ECG blend. This is enough. And that's why we have broad PR, broad QRS, because we are stretching the ECG. Everything will be broad. Correct only, everything will be broad. So that is also very important. So broad PR, broad QRS, P wave is flat. Why? Because we are stretching. Okay, clear. So that is very important for hyperkalemia. These three features: pointed T waves, stretched PR is prolonged, QRS is prolonged, and P is little flat. Okay, T wave is tall and pointed. This will suggestive of hyperkalemia. So that is okay. And hypokalemia under no need. This much spotters are enough in ECG. Okay, clear. Now cardiomyopathies are there. Takotsubo cardiomyopathy, one important. Japanese used to catch some octopus. That's their heart will be like looking like this. Okay, it is known as sympathetic heart syndrome or broken heart syndrome. So high catecholamine level will be there. Because of that, this chest pain starting. Okay, this is known as Takotsubo catching octopus. They have some trap. It is looking similar. The heart is cardiomyopathy looking like that. So cardiomyopathy, we have hypertrophic cardiomyopathy HOCM, and we have restrictive cardiomyopathy, and we have dilated cardiomyopathy. This is also very important because HOCM, hypertrophic cardiomyopathy, disproportionately thickened septum. The normal histology of the heart, fibers will be there. Here the fibers are bizarre arrangement, disproportionately thickened septum, and banana shaped left ventricle. These are the features of HOCM, and you can see pulsus bisferens is a classical features of HOCM. Pulsus bisferens, spike and dome pattern, pulsus bisferens will be there. This cardiomyopathy is purely a pathology concept. It is not discussed in medicine actually, because there are some association. And here, sudden cardiac death occurred due to arrhythmia. You may be hearing some athletes, some people suddenly develop cardiac arrest. Okay, so HOCM, HCM, hypertrophic cardiomyopathy will be a cause here. Disproportionately thickened septum, banana shaped LV, and pulsus bisferens. So these are very important features. Okay, very important features. Okay, so the we should know the beta blockers are drug of choice. Beta blockers are the drug of choice in this condition. Okay, this condition also. And we have something called a restrictive cardiomyopathy, because it is very important, and this is the potential question because it is most common associated with amyloidosis, Fabry's diseases. Fabry's disease, Gaucher's disease, all its metabolic disorders, it is associated. Amyloidosis, definitely they will ask question from this area. Okay, and radiation exposure also causes restrictive R4 radiation, R4 restrictive cardiomyopathy. This is important. And drugs, some drugs like ergotamine and all. So amyloidosis, Fabry's, Gaucher's, radiation exposure, these are infiltrative diseases and causing restrictive cardiomyopathy. That is very important. Okay, management are not important. Amyloidosis, this is a purely patho use. Please study from patho amyloidosis. And management of amyloid, this is TTR type amyloidosis, tafamidis, some drug is there. So leave about this, study this part in pathology. Amyloidosis is very important. Restrictive cardiomyopathy is linked with amyloidosis and Fabry's disease and this other infiltrative disease. Dilated cardiomyopathy, most common cardiomyopathy is dilated cardiomyopathy. Okay, and this is strong association with COVID. Most common causes COVID, viral. Most common causes viral. Alcohol, hemochromatosis, sarcoidosis. These diseases, drugs like doxorubicin, daunorubicin, trastuzumab. These drugs cause dilated cardiomyopathy. This is also very important. You should know this feature. These are highly important area. You should know this part. So drugs like doxorubicin, daunorubicin, and trastuzumab, this is important. Hemochromatosis, alcohol, viral, most post COVID. So people are getting cardiomyopathy and issues. So this is also very important. Okay, post COVID. Okay, clear. So this is dilated cardiomyopathy. This is the pathology part. Okay. So we have something called PDA pathology topic known as infective endocarditis. We should know the CVS pathology. Infective endocarditis, modified Duke's criteria. Major criteria and minor is there. Major is culture positive, and we should know the endocardial involvement vegetations and serology positive for the Q fever. These three features will be there. Minor fever is a minor criteria. This is important. And predisposing valvular condition, vascular phenomena, and these immunological phenomena like glomerular nephritis, Osler's node, Roth's spot, all are minor criteria. Modified Duke's criteria is important for infective endocarditis. But question they will ask like this on fever, they will put in the major, but that is a minor criteria. And the vascular phenomena or some valvular heart effect, that is minor criteria. These culture positive, echogenic echo vegetations are present, serology positive for the serology positive. These are the three major points you should know. This is very important. Other all things coming in minor points, and either 2 major, 1 major plus 3 minor and 5 minor will give the diagnosis of infective endocarditis. You should know, and this is purely pathology. You should know the vegetations and their important classification also. Okay. So we have acute bacterial endocarditis mainly by Staphylococcus aureus. That is also very important, acute bacterial endocarditis. Now we are going to see the very important area, the question area for the exam. Subacute bacterial endocarditis, Streptococcus viridans, post prosthetic valve surgery. So during post-prosthetic valve surgery, up to 1 year, coagulase negative cons, coagulating negative Staphylococcus aureus are the cause for this subacute bacterial endocarditis. After 1 year, Streptococcus viridans are the cause for subacute bacterial endocarditis. And IV drug abuses, okay, Staphylococcus aureus are the cause for subacute bacterial endocarditis. So Streptococcus viridans are there after 1 year of the post-prosthetic valve surgery. That's important. Up to 1 year, coagulase negative cons, Staphylococcus aureus, IV drug abuses, Streptococcus aureus. So you should know all this Staphylococcus aureus, not Staph. Okay, sorry. So in neonate, Staphylococcus aureus is important. So here the important thing, this is the important cons up to 1 year cons. Okay, Staphylococcus epidermidis. Okay, cons. Streptococcus viridans after 1 year. I would all are majority of Staphylococcus, but after 1 year it is Streptococcus viridans. That is the important point. Okay, so clear. This is the potential question they can ask from here. And we know what is the dental procedure. When dental procedures, we have to give antibiotic prophylaxis should be given prior endocarditis is there. If in dental procedure we have to give antibiotic prophylaxis prior endocarditis is present, or any prosthetic valve is there, any cyanotic congenital heart diseases is there, so repaired or not repaired, unrepaired, valvulopathy, prosthetic material used for cardiac valve repair. In these cases, we have to give antibiotic prophylaxis for dental procedure. That is very important. Clear? Okay. So like that, we have something called acute constrictive pericarditis and cardiac tamponade. Both regularly they are asking. We already studied pay tax. Okay. This is nothing but very important in constrictive pericarditis, pericard pay, wide descent, rapid wide descent. Here Kussmaul sign is present. This is Kussmaul sign. Okay. So inspiration, normally JVP falls, but here rise in JVP during inspiration. This is known as Kussmaul sign, which is positive in pericarditis. That is also very important. Okay, cardiac tamponade rapid. So tamponade tax, TAX, rapid X descent is there. There is no Kussmaul. Pulses, paradoxes are seen in cardiac tamponade. We already discussed cardiac tamponade, airway diseases like COPD. Okay, so there what we can say, these paradoxes will be there. Okay, so these are the summary constrictive pericarditis and cardiac tamponade, how to differentiate these two. Antibiotic prophylaxis in the dental procedure and the subacute bacterial. This is purely patho. Bacterial endocarditis is purely patho. Vegetation you should know. Subacute bacterial endocarditis. This is micro also. Up to 1 year cons. Then Streptococcus viridans. Then IV drug abuse against Staph aureus. And in neonatal Staph aureus, this can be asked. Duke's criteria, major and minor, they will mix and give. This is also very important area. Okay, amyloidosis pathology and DCM, dilated cardiomyopathy, because of viral and COVID, alcohol hemochromatosis, and these drugs like DDT, doxorubicin, daunorubicin, trastuzumab. This is also very important. And restricted cardiomyopathy, association of inflicted diseases like amyloidosis, Fabry's, and these coaches. This is also very important. Radiation exposure also very important. So that is there. So cardiomyopathy, HCM, sudden death due to arrhythmia, pulses difference in the HCM, and here heart is so much of fibers, disproportionately thickened septum and disarray, banana shaped LV. These are for HCM, hypertrophic cardiomyopathy. And Takotsubo, Japanese used to do, it's known as broken heart syndrome, sympathetic heart syndrome. There will be serotonin. Okay, and we know ECG changes, hyperkalemia, stretched ECG, and pointed T wave. That is very important. We should know the ECG changes of these all MIs. Okay, anterior wall, lateral wall, and all. Heart block type 1, type 2, type 3. Type 3 complete on canon A waves. Type 2 Mobitz 1. And what are the uses of pacemakers other than atropine in the bradycardia? This is also very important. Okay, ventricular fibrillation very important. And CPR, where to give. We should know polymorphic VT, ventricular tachycardia management, and you should know ventricular ectopic, where should give shock, synchronized and non-synchronized. This is also very important. You should know that also. Okay, clear. Okay, WPW syndrome associated with atrial fibrillation, FAF will go for amiodarone. That also very important. Okay, atrial fibrillation, atrial flutter, paroxysmal supraventricular tachycardia, all are very important area. Management of atrial fibrillation, all are very important. Okay, so you should know all these parts, and you should know ECG, how to decide the axis, how to William Marrow, that is very important. That spotter will come every time. You should know LBH if possible, and you should know this lateral leads and association. You should know R wave prolongation. You should know this symbol area. You will understand the ECG somewhat better. Okay, clear. ECG. Now we already discussed about the acute heart failure, very simple way. So cardiology is this much only, and heart failure different stages A, B, C, D. D for you have to go for cardiac transplants, and C we have to go for ARNI and diuretic beta blocker. Somebody told SGLT2 inhibitor, yeah, but these are the preferences. If it is not working, we are going for the D and the cardiac transplant and assistant devices we have to use for heart failure is very important. Okay, and indication of CABG and thrombolytic therapy and PCI, where contraindication of thrombolytic therapy. These are the regular questions they'll ask. Cardiac markers, and go to pathology and see the important part also there. Okay, so angina pectoris, ACS, STEMI, NSTEMI and STEMI, where ST depression we are not giving. Avoid thrombolytic in ST depression. These are some important points you should know. People are not seeing this and simply applying this in life, and people getting worse on the condition. And ivabradine, they are used to ask this drug. Okay, I4IF, that is also important. Okay, how to manage IHT, angina, this 1, 2, 3, it is typical angina, typical pain, emotional or triggered by the exercise, subside on rest or nitrate. These are the classical features. All three are present, typical angina. And these murmurs I explained in the 13th module. Please watch that. You are going to solve the murmur with this very easy. And this fixed split, wide split, reverse split, and please don't study now. If you want to study, definitely it will trap you. Don't study now. Okay, and this hypertension crisis emergency, what are the drugs should be avoided, pulses paradoxes, pulses difference we discussed. Okay, and this criteria for BP, it is a simple community medicine also, it is there, and the latest guidance also, please check in the updates. Okay, water pulse, aortic stenosis and pulse, and the JVP, which is sure, please watch 5th module of focus 30. JVP is also very important. Okay, so I have discussed cardiology in almost 1 hour 5 minutes, or maybe 1 hour, because of some technical error and issue. I got some problem, and this is my first live, and for next year definitely I will prepare full classes in detail, and I'll explain in detail. Okay, so this was the first time. I don't know how much useful for you. These are the important things. Feel like finished. Okay, you finished this and go and solve immediately. Now only the 25 question or 10 questions of cardiology, and go to the next topic also. Okay, thank you so much. Somebody is there here online. So around few members, 5 to 10 members or 15 members are watched. I will be uploading this video again. Maybe this kind of teaching is outdated. Maybe we have to take the PPTs present, but because of my time is very short, and I'm going live and I'm presenting like this. Anyway, thank you. I'm stopping this session. Thank you so much. Please study well, revise well, do the PYQ. Okay, thank you. Somebody is there here? Somebody is listening. If somebody say bye or thank you, I'll be happy. Thank you, Dr. Lisa. Thank you so much.